Thank you, Ninad Bhai, for a great introduction. Thank you, Singh sir. Thank you, Sushil Bhai. Thank you, scientific organizer for Diabetica 2025 for this opportunity. And today I'll discuss about the very confusing topic, which is like the diagnostic strategy of gestational diabetes. What are the benefits and what are the limitations of different types of diagnostic criteria? So, gestational diabetes impact maternal and fetal health worldwide, and properly diagnosis is very critical in the optimal outcome of fetal and maternal health. And this presentation will compare diagnostic approaches from the major organization. Almost I will be covering around 5 organizations. What are the benefit of that diagnostic criteria and what are the limitations of that criteria. So almost a 14% of global prevalence in GDM, which is very high in Asian population and some other ethnical group as well, and almost as 7 times more type 2 diabetics risk with person diagnosed with GDM, and almost a 25% of macrosomal risk with the fetal who have not treated well in GDM patient. So GDM defined as a glucose intolerance first recognized during pregnancy. So it significantly increased the risk of adverse maternal and fetal outcome. What are the rationale? Why should we screen for and why should we diagnose in GDM? First of all, to avoid the maternal risk like preeclampsia, cesarean sections, and type 2 diabetes after delivery. Fetal risk like macrosomia, shoulder dystonia, and neonatal hypoglycemia as well, and long-term risk for the fetus like childhood obesity, metabolic syndrome, and diabetes development in mother as well. So early diagnosis allows timely intervention, and this reduces the complications and improvement in the outcome of fetals and mother as well. What is the evaluation of diagnosis criteria in GDM? In 1964, O'Sullivan and his partner first time proposed for the diagnosis of GDM, and 1973 they have come out with the two-step method like perform 50 gram glucose tolerance test, and if it is positive then go for the 100 gram glucose tolerance test. In 1979 again National Diabetes used plasma sample instead of the venous whole blood, measuring the glucose level, and the cutoff value were also higher than the before. In 1982, Carpenter and Coston have decided to and propose the CC criteria, and measure the method was changed from like glucose oxidase method. Cutoff value were also again lower than the previous one. In 1999, WHO proposed the GDM criteria, and in again 1999, ADA has recommended for the diagnostic criteria for the GDM. So in 2014, ADA recommended both IADPS, International Association of Diabetes Pregnancy Study Group criteria, and WHO also has collaborated and came out with the criteria, two-step criteria for diagnosis of GDM. Why should we diagnose? Because like it's a one-step approach. You give single 75 glucose tolerance test, or a two-step. First you give 50 gram of glucose tolerance test. If it is positive, like more than 135 or 40, you go for a 100 gram of glucose tolerance test for the 3 hour fasting, 1 hour, 2 hour, and 3 hour. What are the most probable timing for the diagnosis of gestational diabetes? It is 24 to 28 weeks, and it is a like different threshold between the organization that we are going to discuss in this job. First organization is the Indian International Association of Diabetes Pregnancy Study Group. Diagnostic criteria is like testing in the window of 24 to 28 week for the gestational, one step 75 oral glucose tolerance test. If fasting more than 92 or more than 92, 1 hour 180 and more than 182, 2 hour plasma glucose. If it is 153 and more than 153, we can diagnose with the gestational diabetes mellitus with 24 to 28 weeks of gestation. So GDM diagnosed when only one value meets or exceeds the threshold based on the HEPO study outcome. What are the benefit of this particular organization and the diagnostic criteria? Because of the high sensitivity, identify the more cases linked to adverse outcome. Single visit, only a 75 one day you have to call gestation pregnant lady. Fasting you have to check, you have to 10 hours minimum fasting. Then you have to go for a 75 gram of glucose tolerance test, 1 hour, 2 hour and 3 hour. The single visit improve the patient compliance and clinical workflow as well. Evidence based, directly linked with the HEPO study data and on the parental risk as well. International consensus, so facilitate the global research and that data which is available. This approach was developed from the robust observational data. It established the continuous relationship with maternal glucose and outcome as well. What are the limitations of this particular criteria? First one, it increased the prevalence because GDM rate double or triple compared to the other criteria. So the load will be more. Resource burden, like healthcare system maybe struggle with the increased case overload. Benefit uncertainty, like limitations of evidence that treating all the identified cases improve outcome or not. Population validity may not be applied equal to all the ethnical group. So this is a limitation of this particular IAD PSG criteria. Another criteria is American College of Gynecologists criteria. Again, two-step criteria. First step, 50 gram of glucose tolerance test. If it is positive, positive means after 1 hour, if it is more than 35 or 40, you have to go for the step 2, which is again you have to call for the second day for the 100 gram glucose tolerance test for the 3 hours. And they will like a 2 abnormal value need for the diagnosis, Carpenter-Coston thresholds. So fasting more than 95 milligram, 1 hour more than 180 milligram per deciliter, 2 hour more than 155 milligram per deciliter, and 3 hour more than 140 milligram per deciliter. So 2 criteria, 4 out of 2 criteria, if it is more than threshold level, then you can diagnose with the GDM in 24 to 28 weeks. So this this approach is despite the almost the adaptation of International Diabetes Association of PSG. What are the benefits? Established method, long clinical experience in the US practice. Cost effectiveness is that reduce the number of the full diagnostic oral glucose tests because you are cutting down almost half of the patient with 50 gram of glucose tolerance, and patient centered is that. So two-step approach, identify a woman most likely to benefit from the intervention, and it maintain a good specificity while limiting the unnecessary treatment as well. Third one, so what are the limitations of this criteria? Reduce the sensitivity. Higher sensitivity was that IAD PSG, but reduce the sensitivity with the American College of Gynecology criteria. Multiple visit required because you have to ask for the another day to come, because first day you are going to work for a step 1 50 gram. Second day you have to call for the 100 gram. Historical basis, cutoff not derived from contemporary outcome studies. So it was not related with the HEPO study as well. Inconsistent follow-up, almost a 15 to 20% of GCT, glucose tolerance, means step 1 positive woman don't return for the second day for the oral glucose tolerance test. So the two-test approach potentially leaves some at risk pregnancy untreated because they don't come for the follow-up. It evidence basis and less direct than the IAD PSG criteria. WHO criteria again 75 gram of oral glucose tolerance test, one step, 24 to 28 weeks of gestational, fasting 92 or more than that, 1 hour 180, 2 hour 150, and WHO fully adopted by the IAD PSG criteria in 2013. They aligned with that long-standing preference for the 75 gram of oral glucose tolerance test, one step criteria. Benefit of the WHO criteria, again WHO global standardization is there, consistent with the previous WHO focus with the 2-hour values, facilitate the international research comparison and simple diagnosis framework. What are the limiters? Again, it's a limited flexibility for the regional adoption, so ethnical group variation will be there. Resources challenge in the low income setting may not be account for the ethical variation, lacks of guidance for the early pregnancy screening. So WHO criteria support global consistency. However, implementation barrier exist in the resource limited region. ADA criteria for diagnostic approach. First, pre-antenatal visit, screen high-risk women for the overt diabetes. Already diabetes exists for the particular woman who have a pregnancy, like in the first trimester itself. Then diagnostic options are either one-step or two-step approach in the ADA criteria is acceptable. Postpartum follow-up testing for 4 to 12 weeks it's required, and considerably region and population factor flexibility is there. So ADA accept both major approaches. It encourage early screening in high risk pregnancy using a standard diabetes criteria for 1 and 2 step. Our Indian DIPSI criteria, it uses a non-fasting. Whatever the state of fed for the pregnant lady is there, you just give 75 gram of glucose and do oral glucose tolerance test with 2-hour threshold. If it is more than 140, you can directly diagnose with GDM with 24 to 28 weeks of gestational. Simple logistics to resources limited setting. Limitation for this particular DIPSI criteria, it include a lower sensitivity. Ongoing debate about the scientific validity or a non-fasting test is there. So different guidelines like IADPS, DIPSI, ADA, ACOG, NICE and AI IPS is there. So again various criteria what we have discussed is there. This is the table content of that comparison is there. WINGS situation analysis healthcare professional survey. Forget about all the guidelines. Who are following it? Only a 50% of OBGY, 50% of diabetologist or endocrinologist is following this particular guideline. For example, gynecologist referring a patient with me with a 200 of blood sugar. Should I follow like guideline for the diagnostic? Again, I have to like do 1-step or 2-step test or not? With HbA1c of 6.5 or 7, what I do? Should I directly start treatment, or again I have to call them for the oral glucose tolerance test for the diagnostic criteria? That's why only a 50% of endocrinologist and diabetologist following guideline. This is the main concern about OBGY, because first patient for the like diagnostic criteria, they will have a patient. They have to screen all the pregnant lady at 24 to 28 weeks either of the criteria, and they have to diagnose. So we'll discuss the fasting. What is the advantage of only fasting? Simple and convenient for the patient, requiring only an overnight fasting before a blood glucose test. Less time consuming than the other method, making a practical option for pregnant individual. Limitation: fasting testing has a limitations of sensitivity, again potentially missing some GDM cases and leading a false negative as well, because in some GDM patient fasting is always normal. It's only a postprandial which is high, because of first step insulin secretion will be hampered over there. In clinical implementation, while convenient, fasting testing may not be provide a comprehensive picture of glucose metabolism during the pregnancy and may need to be complementary by other diagnostic method to ensure the accurate GDM diagnosis for the perfect diagnosis. Oral glucose tolerance test, it's offer detailed evaluation of an individual ability to handle the glucose, capturing both fasting and postprandial hyperglycemia, which is essential for the diagnosis of GDM. Limitation: it's a time consuming process. It requires an overnight fast and consumption of the glucose solution followed by multiple blood draws. Specified time interval as well, 1 hour, 2 hour and 3 hours. Gold standard status, because despite a drawback, oral glucose tolerance test is a gold standard in GDM diagnosis due to its ability to identify the glucose abnormality that may not be evident through the fasting test as well. Hemoglobin, long-term glucose for the long-term glucose measurement, HbA1c is good, but HbA1c reflect average blood glucose level over the preceding 2 to 3 months, offering a view of overall glycemic control, but it not be reliable in the regularity because of over dilution. As a non-fasting test, HbA1c is and convenient, not requiring overnight fasting and glucose solution. Influence factor can be affected by the iron deficiency anemia and hemoglobinopathies, potentially leading to the diagnostic inaccuracy. There is insufficient data regarding HbA1c for the diagnosis of GDM compared to the other method. CGM, again for the diagnosis of GDM, comprehensive glucose variability captured day-to-day fluctuation in traditional other than the traditional test. Real-time data is there, provide a valuable insight into the glucose control and improve clinical decision to help tailor-made treatment for the plan for the treatment. What are the limitations of the continuous glucose monitoring? More invasive than the traditional test, involve a sensor insertion beneath the skin. Technology isn't universally available, and it's higher in the cost as well. Successful implementation required a specialized training for the patient and a healthcare provider, as well as the expert in the data expertise in the data interpretation for the CGM data as well. Diagnostic method, comparison between the oral glucose tolerance test, HbA1c and CGM. Oral glucose tolerance test is a gold standard with a high accuracy, whereas the HbA1c is a moderate accuracy. CGM, it's again high accuracy, but it's a continuous data and a costlier is there. OGTT, it's a low convenience because patient have to come for the fasting, again they have to drink glucose, then again for the 2 hour 3 hour data is required. HbA1c, it's a very high for the convenience, anytime you can have a blood, no requirement of fasting as well. CGM, low because it's an invasive procedure. For the cost, oral glucose tolerance is moderate, yes you have to like fasting, then again 1 2. HbA1c again low to moderate, and CGM is a very high in the cost. So oral glucose tolerance tests remain the gold standard for the CGM diagnosis, GDM diagnosis due to the high accuracy despite being time consuming and the potential uncomfortable. HbA1c offers a convenience, but its application in the pregnancy isn't well established as compared to oral glucose tolerance test. Continuous glucose monitoring provides valuable real time, but it's invasive and it's costly. With this role in GDM diagnosis still under investigation as well. So it's not again approved with the diagnosis even in the treatment part of as well. So CGM is not that much. Treatment of GDM.
So we are running out of time.
So yes, we all know treatment of GDM is beneficial. It will provide beneficial for the last for gestational age, macrosomia and shoulder dystocia. So maternal and fetal health, it is beneficial to treat GDM. And to summarize, assess all the population for the risk of GDM, then balance between sensitivity and burden you have to consider, and according to it you have to treat the GDM patient. Thank you so much.